Okay, I'll be talking about topography in general and particularly time flux imaging, which is also known as the Pentacam tool that we have now. I'm sorry, the acoustics in the room are not too clear. Am I audible to everyone? Okay, fine, thank you. So, we are all supposed to declare a financial interest in these presentations. I have none whatsoever. Topography has the following clinical applications. The most important being detection of corneal pathology, which is what it essentially came in for, like keratoconus, pellucid marginal degeneration, and other ectatic disorders. A very important use which has come up in the last 2 decades is screening before refractive surgery, especially since the nightmarish keratoectasia has come in. Other uses may be evaluation of the results of refractive surgery, post-PK evaluation for astigmatism, and complex contact lens fittings. I believe that topography essentially has become a maze. Whenever a general ophthalmologist hears topography, one is bewildered and confounded because of the number of various topographers available, the various technologies and techniques that are used there. The terminology per se is very confusing in terms of all measurements, presentation formats, the maps, the color schemes, and the indices, and the analysis software. And when has finally waded through all this, comes the daunting task of reading the maps. Various topographers are available in the market. Most of these are Placido-based topographers. The last two that you see here, excuse me, can I have a point? The last two that you see here are the OpScan and the Pentacam. They are elevation-based topographers. We'll go into the details of all of these a little later. Corneal topography conventionally was the mapping of the corneal surface, but the newer tools like Pentacam and OpScan, they give us a lot more information. They're not just mere topography, but tomography. Improvements in imaging techniques and analysis software have brought about these changes. However, please remember, this is still not an exact science. Most topographers would differ from each other in interpretation, so they actually don't speak the same language. And the biggest bugbear in all this is the consistency of results across various platforms. So essentially there are 2 types, the Placido ring system and the Placido ring system, or the reflective, and the elevation based, there are 2 types, the scanning slit system commonly known as the OpScan, and the shine flux camera based known as Pentacam. The Placido ring system is the oldest and the commonest method, utilizes the reflective property of the cornea. The curvature is measured by the reflections that are measured. The reflected image is captured by the camera and the data is analyzed by the software. The results can be displayed in a variety of formats. Essentially what happens here is the size and distortion of the ring patterns are the basis for calculation. The closer the rings, the steeper the cornea. The further away the rings, the flatter the cornea. This is very simply speaking. There are certain advantages it gives us, like it's an affordable, inexpensive system. There's reasonable repeatability for curvature and astigmatism. It's been around for a very long time, therefore a lot of us have a reasonable amount of familiarity with it, even if we are not cornea surgeons. And in short, it's a good tool. There are some disadvantages though, like it is sensitive to focusing errors, it is sensitive to centering. Errors at the center of the cornea get propagated to the periphery. It is less inaccurate on irregular eyes, and it produces very poor elevation data. Please note that the elevation data given by most of these Placido-based topographers is an extrapolation and not an exact measurement. The maps are commonly presented as colored maps for interpretation. In the Placido-based, it is the corneal curvature which is measured. In the elevation-based, the corneal elevation with respect to a reference surface is measured and displayed. Now, if you see this image, this is a raw image gathered by a Placido-based topographer. There's nothing much you can make out what's happening here. There's some rings, the subtle changes may be there, but the naked eye cannot detect that. When the computer analyzes it, this is how it may come up. So you see a typical pattern over here, known as the butterfly pattern, seen in pellucid marginal degeneration. So in Placido-based, the redder the warmer the color, the red, more towards the red spectrum, the steeper the cornea, and cooler the color, flatter the cornea. That's how it depicts. The maps can be axial curvature or instantaneous, which is also known as tangential or meridional, or elevation map. So very briefly speaking, what I'll try to highlight is axial appear more uniform because of abrupt changes are underestimated. As a result, it gives you a good overview, but subtle changes may be missed. In contrast, tangential maps give a better representation of the local irregularity, but they may bring in artifacts. And axial maps can be derived from meridional maps also. So if you look at this, The top two are the right and left eye axial maps. The middle two are the tangential maps. If you see, this is a nice homogeneous surface. You can see how the colors are there. Here you can see the breaks in between. There are areas of relative steepening in between the areas of relative flattening. So this is a more detailed map of local irregularity, but sometimes artifacts can come in. This gives you a good overview, but sometimes we underestimate local pathology. Various topography patterns may be seen in keratoconus. The most pathognomic is a skewed radial axis. Basically what happens is, if you have a we all know the bow tie pattern. If there's asymmetry, it may be indicative of keratoconus. If there's skewing of the axis, like you see in this diagram number 7, this is basically there's no skewing. This is the upper lobe, this is the lower lobe, and they are aligned. Any skewing more than 22 or 30 degrees, different authors have different views on that, may be diagnostic of keratoconus. And especially so if there's asymmetric bow tie pattern like in this one with skewing of the radial axis. So this is the most pathognomic, but all these patterns will be seen in keratoconus, like this one, inferior steepening. This is another central steepening, inferior steepening, very irregular pattern, irregular asymmetric bow tie with skewing, asymmetric bow tie and asymmetric bow tie with skewing. So these are some of the patterns. I just want to show you some images of a Placido based system. This is essentially a normal cornea. You can see a nice smooth green surface here. Green is like the central area. It's about 44 diopters. So it shows a nice cornea which is quite smooth. Another cornea which is normal but shows with the rule astigmatism, the steeper on the horizontal meridian. This shows an asymmetric bow tie pattern. This is the smaller lobe, this is the larger lobe, but there's no skewing seen over here. This is an asymmetric bow tie with skewing of the radial axis. If you see this one, the axis is here and the axis for this one is here, and it's more than 30 degrees. So this is skewed radial axis. This is quite indicative of keratoconus. So again, this is a different topographer, but again a Placido based system. Skewing of the radial axis, you can see with the asymmetric bow tie. This is a post-LASIK ectasia. A post-LASIK ectasia and a keratoconus on topography may appear to be very similar. This is a pellucid marginal degeneration. You see a typical butterfly pattern here. This is very indicative of PMCD. So basically, these were some of the Placido-based topography things that I discussed. Let's go on to elevation-based topography. They provide much more information than topography alone. We'll see the reason why. There are two types, the scanning slit called OpScan and the Scheimpflug called Pentacam. Now let us see the reason why elevation topography came in. If you see this curve here, there are two segments, A and B and C and D. The curvature, spherical curvature of AB and CD, both the segments is the same. The curvature is the same, but there is a difference in the elevation. A is more elevated than C and D. And as you know, ectatic disorders like keratoconus, there is an elevation. So therefore, it may make sense to have elevation-based topography also. Now, this is a Google Earth image of Himalayas. You see the certain peaks over here, like the Everest, and then you see the valleys. But you know, Everest is about 8.5 kilometers. But when you see from space, when a satellite sees, all you see is that there's not much of a difference between the peak and the valley. Therefore, to know, this is what happens in the cornea. There may be subtle changes, but the naked eye may not be able to make out. The slit lamp also may not be able to make out. So what we need to have in elevation-based topography is a reference surface. A surface with reference to which we know that this particular point A, is higher than that surface or lower than that surface. So that is very important. And therefore, the concept of a best fit sphere has come about in elevation-based topography. It could be sphere, it could be anything, but the commonest use is the best fit sphere. So if the yellow line is where the corneal surface, this is a gross dramatization over here, you could say. But then the system will construct a sphere, a surface, very close, the closest to all the points on that cornea. So that is called the best fit sphere. Anything lying above will be depicted by warmer colors. Anything lying below that surface would be depicted by cooler colors. So that's what I wanted to say here. Anything higher is anterior, is by warmer colors, the redder colors, and anything cooler will be in the blue zone. So just a little, now what I'm going to discuss now, just spend a minute here. Do we have some time? I think it's a 15 minutes. We have some time, right? 5 minutes. Okay, that's enough. Okay, now what I'm going to discuss here now is basically a little difficult to understand this concept. In elevation-based topography, if you see, there's this dark green line and a blue line. the curvature rather, the dark green one, what you see in the center is the best fit sphere. So if this were the point, common point, a steeper cornea, this dark green is the steeper cornea, you'll see the periphery of this cornea going below or posterior to the best fit sphere. So therefore this periphery would be depicted by a cooler color, that is the blue color. If you see this dark green line, the periphery becomes blue. The central is the normal cornea area, normal elevation, which is green for both. You see the sky blue one, the periphery is anterior to the or above the more elevated than the best fit sphere. So this would become redder. So this is how a elevation topography would look like. Let's contrast it with the normal, regular or rather Placido based topography. This is your Placido based topography. The same cornea, the steeper, this is the steeper axis we know. This is how, the red is the steeper axis. This is how it would appear. The colors are like this, the warmer colors towards the steeper. But here we just saw that the steeper axis was, the periphery was going below, therefore it was represent blue. So therefore there is a sort of a color reversal. So when you first see a elevation based topography, you might be confused. You might say this is the steeper meridian, but in effect this is the flatter meridian, but this is actually the steeper meridian. So this is what I wanted to highlight. A little difficult to understand initially, but eventually you will understand if you keep doing this. Now slit scanning system, the OpScan, I won't dwell too much on it because the idea was to talk about the Schoenflug imaging. This has a dual technology, a hybrid technology. It has Placido discs also, and it also has a scanning slit. It measures the anterior surface, the posterior surface, the curvature maps in terms of keratometry, and the pachymetry map, along with certain information given here, which is very critical in certain surgeries now, like the Axial. They give you the white to white, which no other topographer is giving, and they also give you the antechamber depth. From the endothelium side you can have it, which is very important, although Pentacam also gives that. So only elevation based topographers would give you the anterior chamber depth. The advantages are that there is a superior elevation curvature data by combining slit scanning and Placido systems. So we get both elements of both. But it has been around for some time, and the results in certain cases, like especially post surgery, they are not very good. And a patient who has undergone LASIK or a C3R, there are certain confounding error variables over there, and therefore in such patients OpScan may not be very reliable. But it's still the most widely used elevation based topographers. Pentacam basically is a relatively newer tool. It uses a rotating Schoenflug camera. The Schoenflug technique, we'll just go into that, provides sharp and crisp images of the anterior segment. From the anterior surface to the posterior capsule of the crystalline lens, right from the cornea, anterior surface of the cornea, right to the posterior capsule of the lens. This rule basically describes the optical principle upon which this device is based. In conventional cameras, any conventional camera, you have a film which is the object, you have the lens, and you have the subject which is the subject which we are photographing. They all have to be parallel in the same plane. But in the Schoenflug principle, they can be inclined, and this is how it works. You see, this is the camera film, this is the lens plane, and this is the subject plane. So what it helps us do is, like objects in the axis of the lens can also be seen. So this gives very precise measurements, and it gives us all sorts of information like pachymetry, topography, elevation, both anterior and posterior. A cataract analyzer is also built in. It gives a Bellin-Ambrosi enhanced ectasia map, which I'll just talk about. A holiday report, which helps in post-refractive surgery patients who are undergoing cataract surgery, and a tomography also. And it takes about 2 seconds to measure all this. Again, it's a 4-map display essentially. There are various formats, but the most common is the 4-map refractive. And you have drop-down menus. You can actually choose which particular one method you want. I'll just take 1 minute more. 1 minute beyond this. Okay. So, just to go into the screening parameters, there's the best fit sphere that I talked about. The variation in the size of the best fit sphere would influence the shape of the topography, or rather the topography data that we get. So whenever we do this, we should check the best fit sphere. It could be system dependent, or it could be 8 or 9 millimeters, which we can choose and set for ourselves. Anterior elevation map. Sorry. So in the if it's a 9 millimeter zone of best fit sphere, the best fit sphere is given over here. I'll just show you. This gives you the best fit spheres, these areas. So basically in the anterior elevation, anything beyond 15 microns is indicative of keratoconus. And in the posterior surface, anything beyond 20 microns would be suspicious or indicative of keratoconus. In the 8 millimeter zone, the similar values are 8 microns for anterior surface and 16 microns for the posterior surface. So this is where you have to see the values. If you're seeing the elevation of the back surface, this is the 8 millimeter zone, you know 16 is the value that you can have. So all these values that you've seen up to this this last circle are within the 16 millimeter zone, within the 16 micron range. And in the front surface, they are within the 8 micron one. But if you see another one, you can see that this is going much beyond. This is plus 44 on the front surface, which should be just about 8 microns. So this is very indicative of keratoconus. But then you have some other tools also, like the Berin-Ambrosio enhanced ectasia, which helps you diagnose. Basically what happens is, I'll just go briefly over this. We're talking of the best fit sphere. Now if you see this, this is the keratoconus fit with cornea, fit with the best fit sphere. This is the best fit sphere. And the normal cornea with the best fit sphere. In the keratoconus, we see this bulge here. Now, what Berin-Ambrosio says is, we take the point of maximum minimum thickness, and 4 millimeters around that, we remove that area. We don't consider it. So this little bulge that you see is not being considered, and then you draw another best fit sphere. The system does that. So this is what you end up with. And the difference between the two would be very significant and indicative of a keratoconus. But if you were to do that in a normal cornea, you see the best fit sphere. And if you remove the 4 millimeter zone around, it won't make much of a difference. You'll still end up with the best fit sphere, which is almost matching the normal cornea, the original one. And if you take the difference, there won't be much of a difference anyway. So this is how it goes. This is the normal best fit sphere. This is when we remove the 4 millimeter zone, called the enhanced fit, and this is the difference. So it works like a traffic signal. Whenever there is
Dr. Agarwal?
Yeah, okay, just finish. Just finishing. It's like a traffic signal. You have a red, that means you stop. You have a yellow, be careful, and green, that you can go ahead. So the front surface is green in this case, but it is red in the posterior surface. So in conclusion, corneal topography is an important tool today. Requires some effort to understand initially, but it is important for detecting ectatic corneal disorders like keratoconus, keratoectasia, others, and refractive surgery screening also. And the newest topography systems perform multiple functions and may provide more value for money, but there's no ideal and perfect system available yet. Thank you for a patient hearing.